We are live again on International Weekly Meeting from CMAAO. We meet every alternate week to discuss an important topic. Today is 13th of July, and uh, we have a very important topic on diabetes. I think it's a need of an hour. We talk about sugar control measures and the diet and everything. So we have Dr. Banshi Sahoo, who's taking care of this session today. He's a chief diabetologist and a chairman for diabetic care of and hormone clinic, Care at Ahmedabad. He's also chair-elect of IDF from Southeast Asia. And we are talking about primary to primordial prevention of diabetes. Sir, over to you.
Thank you. Thank you, Saurabh, for kind words of introduction. Thanks, IGCP, for giving me this opportunity. And this is what I'm going to talk from primary prevention to primordial prevention. So I'm just sharing my screen and uh, can you see my slides?
Yes, you can. We can see that, and you can. Yeah, perfect.
Just so you can see my slides. Huh? All good?
All good. Perfect.
So in next 25-30 minutes, I am going to talk on a very important topic from primary to primordial prevention of diabetes in India. And for this, I have nothing to declare. As we know that this dreaded disease is shaking our foundation. If you see in India, at present, we have in 2023, the data is showing that 101 million people with diabetes, having 101 million adults have diabetes, but this incidence is increasing. And if you see that globally, the increase is almost 45%. But in India, as new prevalence and incidence is increasing, we have 123% increase in incidence of diabetes in our country. So if you think of prevention of diabetes, I think we have to intervene much early to prevent diabetes. We have not to wait for someone to become a pre-diabetes or someone to have a more risk factor for developing diabetes and then you start preventing for them. But rather we have to start much early to prevent the diabetes if we really want something for a primordial prevention of diabetes. This is IDF data, which has been published in 2021. All over the world, increase in diabetes there, but it is more with the Southeast Asia in compared to North America and some other parts of the world. But definitely the Africa and Western Pacific also have high number of people who are becoming diabetes in that country. In 2017, we had given a white paper regarding diabetes-free India. Is it possible that we can primordially prevent the diabetes? And we met honorary president of India at that point of time in 2017, and what we talked to him, that we can think of diabetes-free India, which means that children born after 2030 should not develop diabetes in their lifetime. And that was what the paper which we had given, for which he had endorsed it. And when then we started talking to the other departments of uh, healthcare department, the government, education department, and many more, and with the signature of him and with his blessing. And we talked about that, yes, we have to work more for the young girls. The counseling young girls to eat healthy and stay physically active will lead to an increase in their muscle mass. We have to make them healthy mother. The primary goal is that we should work on these young girls, and after 10, 15, 20 years, when they will be mother, they should be healthy mother. The healthy mother means they should have more muscle mass. They should deliver a healthy baby. They should deliver a very healthy baby, and they should not develop any problem during the pregnancy, or rather before pregnancy, we have to make them very healthy. Once the child is born, they should have a healthy life in their school going time. That is what we want to include, a health science booklet in their curriculum. And for that, we met at that time in 2018 NCRT, also promoting more sports at school level, encouraging schools to provide healthy food at canteen, and then a healthy youth. It means that after the school, when they are in college life or then early adulthood, they should be given again this healthy environment, increasing physical activity, more of a public transport, and this should continue with that throughout the lifetime for maintaining increasing physical activity. Probably if we do every aspect of this, we can think of prevention of diabetes, and then we can call someone as a for primordial prevention of diabetes. This is the data which I was talking about, 101 million people with diabetes which are diagnosed in our country. But we have other metabolic problems also, like abdominal obesity, the dyslipidemia, the pre-diabetic population, more of a blood pressure. So you see all these risk factors are responsible for increasing cardiovascular disease in our country. So when we are talking of primordial prevention of diabetes, actually it is preventing all sort of non-communicable disease. It's not like that you are primarily targeting diabetes, but definitely you are decreasing the cardiovascular disease and increasing the but this peak is actually starting in 30. In 25 to 30 also we have seen in the Western population, we see this peak in their 50s. So there is a almost 1 decade earlier, we are developing diabetes in our country, and that's increasing more and more. One of the important reason is that we have hyperglycemia pregnancy, that is GDM, is more in Southeast Asia, in Indian subcontinent, in compared to other parts of the world. So there is a strong correlation between a GDM or a pregnancy, a hyperglycemia pregnancy, and then future offspring developing diabetes in lifetime. There is one more problem is now India is suffering from a called affluenza because of people are becoming more affluent. They are become more sedentary all the time sitting and increasing consumption of diet, which is more of a refined carbs or more of a
I think we have lost the connection for Dr. Saboo. Dr. Saboo, are you still there? Dr. Saboo is joining in from Trivandrum. He's traveling and he is in a hotel. I believe the connection is unstable, so he will join us back soon.
hello.
Yes, sir, you're back. I think you lost the connection.
I don't know because
In the middle also, I think we saw the connection lost, but it was okay after that. So we'll continue.
okay, just a minute.
Wow, you have a busy screen.
Now, can you see it again?
Yes, we can.
So I'm sorry if in between I lost the connection. And this was what I was talking that we met honorary president and to talk about primordial prevention of diabetes in our country. And we talked that young girls we should work more, that counseling young girls to eat healthy and remain physically active. So we have to make them a healthy mother. A healthy mother will deliver a healthy child, and then we have to work on them for a pediatric in young adult in adolescent life and as well as when they become adults, and then we have to keep them physically active, and there should not be increase in fat mass and essential obesity. That's the what the primary goal. So from young from the fetus to till they become adult, we have to continue to work if we really want to prevent the diabetes. And then I talked about different metabolic risk factor for cardiovascular disease. So it's not just diabetes which is responsible for increasing heart problem, but if we work for diabetes prevention, I'm sure we will able to prevent all other problems too, because dyslipidemia, hypertension, central obesity, generalized obesity, they all have the common reason for them why someone is developing diabetes or central obesity. In India, we see the peak in 40s, while in the Western population, this is in 50s or even 60s. But we started getting now patients with diabetes even in their 20s and even lesser than the age of 25 too. One of the important reason is that we have getting hyperglycemic pregnancy that we call GDM or a early GDM is much more common in Southeast Asia region, which is Indian subcontinent, in compared to other parts of the region, in other parts of the world. So that is one of the important reason why we are developing a child which is having high fat, and from childhood it is we are actually thin fat Indians. We are also getting more of a affluent problem because of this, we call it affluenza. It's a decreasing physical activity and increasing body weight, increasing central obesity, and the reason is simple, that in decreasing physical activity and more increase in refined carbs and fat which what we are eating. If you see the life course, there is always a possibility of prevention of diabetes at every stage. So even at the fetal stage, when improving the maternal nutrition, even at the infancy and childhood, to talk and educating the pediatrician to the school teachers and creating an environment where we can make them more active in adolescent, for increasing physical activity, giving them a health science booklet, and then in adult life increasing their more of a standing culture rather than a sitting culture. Probably if we change all this behavior in the society as well as the person, there is a possibility of decreasing diabetes incidence, and we can prevent diabetes. Maybe not just primary prevention, before that we can do primordially prevent. So at present, if you see all over the world, all those trials and everything is talking about the primary prevention. Primary prevention means those who have already developed pre-diabetes or at the risk of developing diabetes. But we have to work with the normal population if we really want to decrease the incidence and prevalence of diabetes. The normal population itself is already at the risk of developing diabetes, and the second generation should not develop diabetes. That's the reason we have to primordially prevent the diabetes. If you see the global map, the Indian subcontinent is very typical. We are having a birth weight of a child is less than 2.8, while the Western population or the North Europe population, or you see the North American population, the average birth weight of a child is around 3.3. But again, it is very peculiar that we are the one who are having highest number of people with undernutrition, low birth weight child below the age of 5, but one side we are having highest number of people with type 2 diabetes. So such a paradox is there, that one side you have undernutrition problem, maximum low birth child in the world, while other side we have highest number of diabetes. So there is a strong correlation with this. And this paper, which is published long back in 2002, that Indian average baby birth weight is 2.8 kg, while the Caucasian or the English baby birth weight is average is 3.2. But what big difference is, even we have a birth weight of 2.8, which is smaller child, but still the fat percentage of in that child is more than 25%. It is more than 25%. While in a Caucasian child, the fat percentage of that child is less than 15 or less than 20. So it is mostly between 13 to 17 or 18% of the fat which is seen in the Caucasian. So by birth itself, we are thin fat. That is what we have: higher visceral fat, we have less muscle mass, we have high insulin even at the time of birth also, and we have low adiponectin. So that makes that we are highly insulin resistance even by at the time of birth. So we have to change this, that we have to get also a healthy baby. We should be 3.2 kg with a less fat percentage even at the time of birth too. And then what happens the Indian scenario? This low birth weight child is given a overnutrition. Instead of increasing his physical growth and muscle mass, he is actually increasing in his fat. He is increasing in his abdomen fat. Even you can see the lower class people also, now we are seeing with the protuberant belly, and they are also having increasing fat mass inside their belly. This one more paper of Yagnik, which he looks very lean and thin. You can see on the right side that Dr. Yagnik is having the BMI absolutely normal, which is 22. And he compared himself with a Professor Yudkin. Both of them were working in UK and they both have same BMI of 22.3, which is absolutely normal as per the Asian cutoff. But if you see, the fat percentage of Professor Yagnik is 21.2. Even he looks more thin in compared to Professor Yudkin, and his fat percentage is 9.1. He looks more muscular, and his fat percentage is only 9.1. So this thin fat, which was there in the at the time of birth, it remains even you remain with normal weight. Still, the fat percentage of a normal weight without even breast circumference is high. Still, the fat percentage in India is very, very high, and that's what the concept of thin fat Indian is being given. So we are Indian phenotype is very typical with less muscle mass, with more fat again in the visceral fat, more in the central part of us, and this makes you to more prone to develop diabetes. And we develop diabetes almost 1 decade earlier than Caucasian. We develop diabetes at a lesser BMI. We develop diabetes even our mid-arm thickness or mid-arm circumference is less than 20% in compared to Caucasian, and we develop more of fat percentage in our body. So what we should do with a who is low birth weight child, rather than increasing his adiposity, we should try to increase his lean muscle mass and the length. And for that, we have to work for 2 generations, because those who have already born with low birth weight, what we can do is we have to increase muscle mass and their bony mass. We can't do now anything. But the next generation we want, they should have also, we should have our newborn in India, maybe around 3 or 3.2 kg. That is what the mean birth weight we should improve. Rather, we are talking of maternal mortality rate, but we should also talk about what is the normal birth weight for our child, and what happens whether they develop full term delivery should be more promoted, and we should get more of a vaginal delivery rather than cesarean section. And how we can reduce that? If the pregnancy will be completely uneventful, they should not develop any hyperglycemia in pregnancy, they should not be malnourished, they should have the normal, we have to make them a healthy mom. Otherwise, this cycle will keep on doing, and mean we will get either low birth weight child, or and then we will have PCOS, obesity, again malnutrition, and then once they become pregnant, again they are going to develop all those complications, which will lead to a child which is of low birth weight too. So the womb may be more important than mom. That's healthy moms have a healthy baby, and that is what our concept is. Even with the child who are born low birth weight, they are not only having high incidence of diabetes or a metabolic syndrome or a dyslipidemia, but they also have high incidence of cardiovascular disease too. Even they may look lean and thin, they also have high risk of respiratory disease too. So it means they are at adult onset, they have multiple different non-communicable disease are very common with these low birth weight child. So what the solution? If we solution is only lifestyle, no, we have to target the maternal malnutrition. We have to target the childhood overnutrition. So these are the two very important aspects. Unless we work on it, someone who is already pre-diabetic, who is already obese, yes, definitely lifestyle should be changed for them to become healthy, and we should try to prevent. So primary prevention should continue, but at the same time, if we want, before a person becomes at the risk of developing diabetes, we have to target maternal malnutrition or targeting the childhood overnutrition. So preparing every female child for a healthy motherhood, that should be our target for that. And for that, we have divided that even if someone is in the age group of 0 to 5, we should have some action plan for them, promoting breastfeeding, avoid direct sugar, responsive feeding, controlling screening time, risk assessment, as appropriate physical activity, sleep hygiene, growth monitoring as per birth weight. Even for the school going children, there should be a health science booklet, growth monitoring, healthy diet, discourage fast food everywhere, physical activity should be promoted, more sports, screening for obesity in a pediatric age group. The teenagers and adolescents, again, because they are at the higher risk of developing obesity, they should be more counsel, more peer support, digital health engagement, more of a workshop, and lifestyle change campaign should be given to them to improve their health. For that, the young adults, now this is the reinforcement of all those healthy habits which is cultivated in their childhood. Education on obesity and diabetes should be continued, comprehensive health monitoring, More important is a standing culture that should come in them. Instead of sitting all the time, they should stand more. They should have more of a fitness challenge and incentive should be given. Culture of more standing should come in the and in a system. Then they will be more standing, and then probably that will decrease the incidence of diabetes. Two, the middle is adults, those who have but low birth weight, but now they are at the high risk of developing diabetes and cardiovascular disease. So they should be prevented from that. That's what the primary prevention can be done. And their muscle mass increase is the most important thing, because otherwise the sarcopenia is one of the important reasons for them to develop all other complications. Those who are already elderly, they have already developed diabetes or they may have some complication. So there they should be screened for the complication. They should be secondary prevention should be done for them. If they have already developed complication, the further progression of complication can be halted, and the prevention of sarcopenia, more of a muscle strengthening exercise, nutrition, and physiotherapy should be continued for these. So improving a health of every female child is very, very important, and we should have a very multi-pronged approach for preventing diabetes. Now, one approach is that improving the maternal health, maternal nutrition, and in utero environment. The other side, we have to work for a urbanization, unhealthy diet, sedentary lifestyle, lack of exercise, and stress. So, on both the aspects we have to work till we get for next two generation or three generation later on. We will also have a very healthy child and a complete environment become healthy. So then probably we have to work with all the people for more continuously educating them for healthy life. Once we will have this unhealthy life, sedentary lifestyle, increasing exercise, that will prevent definitely obesity, prevent diabetes, and those who have developed already diabetes or some complication, the further complication can be prevented or their complication progress can be reduced. While if we take care of maternal health and improve the maternal nutrition or improve the in utero environment, we are going to have the next generation which will be of normal birth weight, and probably next to next generation will be definitely with normal birth weight, with a healthy newborn, with less insulin resistance, with less risk of obesity and diabetes throughout the lifetime. And that is what a intergenerational impact will come. That will be for next two generations. If we have this multi-pronged approach, we are going to have take care of these two, three generation for diabetes, and we can primordially prevent diabetes. And maybe after 2030, maybe in 2047, now that is what this year we had given to our honorable president, a paper that we can prevent the diabetes in 2047, when 100 years of independence we will be celebrating. In next 25 years, if we continue work on all these aspects, we will continue to help people who are developing actually diabetes in young age, which can be definitely prevented. We had given this paper to the health ministry also, and again we are now in process of talking to all of them. To conclude my talk, invest in health of a female child, inculcate the healthy habits in early childhood. School curriculum, we should involve the health and fitness guide or a book. Workplace, we should have more of a standing culture. We should incentivize the healthy habits. Above the age of 45, a regular health checkups and preventing complications is very important. And those who are above the age of 65, prevent them from the sarcopenia. So we can definitely change the natural history of type 2 diabetes. We can completely change it, and let's close the gates for diabetes. Definitely, uh, we can think of a diabetes free India. We can think of diabetes, type 2 diabetes can be prevented. May not be in immediate future, but maybe down the line in two or three generations. To know more about prevention of diabetes, this year we are doing a World Congress of Diabetes, Prevention Diabetes in India. That is WPCD, one of the world famous congress on prevention of diabetes in Mumbai. And if you are interested really in diabetes prevention, come and join us with this. Thank you. Thank you very much.
And with knowledgeable talk, I would like to invite everyone. Please raise your questions. We have Dr. Monica. Dr. Monica, would you like to make comments on it?
Thank you so much for a great topic and for really succinct points to be shared. I really appreciate your long view. It's not just about diabetes in the individual at that moment, but it's looking at the next generation and focusing on the women and their children. And looking at the initiatives that you're creating is very nice. It's very interesting what you said about lean fat. I'll tell you that even looking at Asian babies born in North America, this is exactly the same thing is happening here. You'll see that there's lower weight babies here as well. And these children are still at risk for having metabolic diseases. So it's very interesting that our genetic background makes us at risk, and we need to be aware of the risk that uniquely identifies us and how to combat it. So I really appreciate your incentives.
Dr. Saboo, are you still there? I think we lost the connection again with him. Yeah, we lost the connection.
Yes.
We are back. So thank you, Dr. Monica. And so there's a question in the Facebook which says, how do we...
Monica, what could be the reason for the South Asian who are even in North America having the low birth weight? Do you think it is something which is genetic? We can't change it because we are thinking constantly that we can have it, and we are now developing a study also and doing that, by improving the maternal health and working on the children who are in their age group between 8 to 12. If we work on them and if we make them healthy, then we can think of making them healthy after 15 years, and when they will be having the children, probably they will have a normal birth weight child also. And we are now doing for them a normal birth baby, what is their fat percentage, because this is very important. The fat percentage of an English baby compared with Caucasian baby to Indian baby, we want that, if we can decrease from by birth the fat percentage, then this thin fat concept, we are highly insulin resistant. So with a 22.3 BMI, you can see the Yagnik, even his fat percentage is high. So as soon as his BMI will increase, his increase in visceral fat, he will develop diabetes or he will develop all cardiovascular disease. So, we have to work on it. That
Yes.
even at the BMI, normal BMI, people are developing diabetes or they are highly insulin resistant. So this is what a 2-generation impact we have to create. Unless we work for 20, 30 years, we can't reduce the incidence and prevalence of diabetes in our country.
Yes, and I think you answered the question you asked, like why is this that we're still noticing that here in North America? I don't think we've had enough 2 generations to be able to offset.
Exactly.
And I think that we are also carrying along the same dietary habits of our
Very
parents and our grandparents. So we have not fully identified the role of trying to increase muscle mass to be able to address the visceral fat that we're not able to see, and we're comparing
Rather, they have
ourselves.
become more sedentary. Some of them have become more sedentary, more obese also while going in US.
Yes, thank you.
Dr. Saboo, we have a question which says that how do we detect early diabetes among the young generation?
So we have recently written a paper that, in India, as per the ICMR guideline, above the age of 30, everyone should be screened for the sugar because of high incidence of diabetes. But those who have, there is a Indian diabetes risk score. If you have a family history and central obesity, they should be screened even the adult life above the age of 18 also. But recently, as we have done a defeat diabetes campaign, and where across the country, we found that many people who are not diagnosed and first time detected diabetes even below the age of 25 also, even below the age of 20. So as I told you that we are at the higher risk of developing diabetes in our country, it's better that they should be screened. So any opportunity for a doctor, if they come to the clinic, it should be screened for that. And as I told you, one paper which is talking about the sugar is becoming like a 5th vital sign, as every doctor has to see the pulse, blood pressure, temperature, and respiratory rate. These are the 4 vital signs which are checked. Simultaneously, he should also try to check the random sugar. If definitely one random sugar is not sufficient to diagnose person with diabetes, they can be sent for A1C or 2 times report of random blood sugar if it is more than 200, or they can be given OGTT also to confirm the diagnosis. But the incidence and prevalence is so high that people are not detected diabetes early in the course of diabetes, and they are detected with 5 years, 10 years after, or 2 years after, and they come to us with complication only. So, early detection and early and aggressive management is the only way by which we can prevent diabetes complication.
Okay, but apart from like going to a medical side of it, going to a doctor, if somebody who's perfectly fine, the problem is
So there
we
is
are
an
not able.
Indian diabetes risk score. So the best thing is if someone wants that I don't want to be diabetic or am I at the risk of developing diabetes, a very simple tool is waist to height ratio. So if your abdominal girth is more than half of your height, you are at the risk of developing diabetes. It's so simple. So, for arm population, arm janta, for everyone who just want to know that whether he's at the risk of developing diabetes, for lay people, this is the best way. They have to just check their abdominal girth. If my height is 170 centimeter, my abdominal girth should not be more than 85 centimeter. So simple calculation.
Okay. Okay, perfect. And is unexplained weight loss?
Yes, so that is what the severe insulin deficiency. That is insulin deficiency diabetes. That is not related directly with type 2 diabetes. So we are dealing with two varieties of diabetes. One is type 1, another is type 2. So insulin deficient diabetes, they will lose the weight. So sudden loss of weight is more gives the clue about the insulin deficiency. But some of the patient type 2 diabetes who are not diagnosed initially and then they develop sugar which is very high, like more than 350, and then they start decreasing the weight. Suddenly they start increasing, thirst and going for urination again and again, and they start decreasing the weight. That time they are also diagnosed with type 2 diabetes. So that's the second condition. But most of the type 2 diabetic patients in our country are asymptomatic and they are detected on a routine checkup only.
Okay. And there was another question which is not linked today, but I think it came up in another forum, but it was linked to diabetes, which I still remember. If somebody who doesn't have a diabetes, they can have a regular sugar and it doesn't affect diabetes. But once you have a diabetes, then you should not have a sugar. Is that true?
So then they should not take the sugar. Is it like that?
So the question is that if you don't have diabetes and if you don't have a history of diabetes, you can consume the sugar
So the
and
sugar
sugar
consumption
cannot cause diabetes.
sugar is not good but for anyone, for you, me, or for any normal person, because it is not only increasing your calorie uh, content
Taking.
of it, it's not the natural way of taking it. So it's not good. But we always say that if you can reduce your sugar consumption, and definitely once you diagnose with diabetes, we have to completely stop because there is no medication that first phase of insulin secretion goes away completely. So even a small amount of sugar, if they will take, once you become diabetic, that is going to increase the sugar level. And that's the reason we definitely say that once you become diabetes, you have to forget the sugar consumption at all. But even someone who is not a diabetic, it is better not to consume direct sugar or at least try to reduce as less as possible.
Perfect. Uh, do we have any other questions on the floor? So there's one more question which I have. Recently, you've seen a trend where people are putting patches and they're having a lot of meals and they're trying to show whether the sugar is going up and down. They're
So that
trying to
is
evaluate and
continuous
testing
glucose
process.
monitoring. Yes, so
Sorry?
that's a continuous glucose monitoring. So
Yes.
the
So is
CPM for the diabetic patient, definitely it helps them for sugar management, for optimizing their therapy, for the diet control, for exercise, for everything. But those who are non-diabetic, they also started using it just for their calorie consumption to reduce, just to see their fluctuation and just to reduce their direct sugar consumption. That's the reason they are also using sometime continuous glucose monitoring.
perfect. So if there are no more questions on the floor, we would like to give Sir an exit. I think he has a
Yes, I have a meeting.
session in another 10 minutes. So thank you for joining in from Trivandrum.
Thank you.
We have Dr. Angelique. Dr. Angelica, hello, and we are saying bye to you. You've just joined late. She's joining in from South Africa.
Wow.
Thank you.
Thank you.
So I will send you the recorded session, Dr. Angelica, for you in the group, and we can have a follow-up session from Sir. I think it's a very good topic, and since we have a short of time, we'll take it next time. Thank you, sir, for joining in.
Thank you. Bye-bye. Bye, sir.
So thank you, everyone, for joining.